This is a 60-year-old white male who presented with a non-healing ulcer of his right foot. The surgeon requested a diagnostic arteriogram prior to performing a bypass surgery. We prepped and draped the patient in the usual manner, did a left leg puncture, and this is the aortogram that you see. The renal arteries are well visualized. There are lumbars that are prominent but unremarkable. The inferior mesenteric artery is patent. There is a 70% stenosis in the right common iliac artery. It is heavily calcified and irregular as well. An oblique view revealed slightly more information around the common iliac artery. The origin of the internal is unremarkable. The external shows no significant disease. The profunda femoris is widely patent. The proximal superficial femoral artery is normal. The distal SFA and proximal popliteal artery are markedly irregular throughout their course, and the distal popliteal artery is patent. The anterior tibial artery is occluded through its course. The tibial perineal trunk is unremarkable. The perineal artery, although small, is continuous. The posterior tibial artery is continuous and crosses into the foot, providing all flow to the foot and collaterals to the dorsalis pedis. At this point, the surgeon and I discussed this, and he requested that we stent that right common iliac artery lesion with an attempt to provide better flow down the right leg prior to his bypass graft. We then punctured the right groin, put a guide wire up into the aorta, and provided you with these pictures. At this point, we then placed a 12 millimeter Luminex, a 12 by 6, as well as a 12 by 4 millimeter Luminex, and this was angioplasty to a 12 millimeter size. There was no significant lesion at the completion of this stenting, and you can see that the stent does extend into the abdominal aorta, which was our plan. Follow-up studies revealed no abnormality noted, and the patient was doing well. We pulled both catheters, provided pressure for approximately 10 minutes, and then the patient was about to be moved off of the table when he complained of abdominal pain. His blood pressure suddenly plummeted, and we repunctured both the right and the left side. Midstream abdominal aortogram was obtained. You can see that the renal arteries have shut down. There is extravasation noted from the right common iliac angioplasty and stent area, and the vessels are all quite small. At this point, we punctured the left side, put up a guide wire as well, placed a 10 by 6 fluency on the right side with a 10 millimeter angioplasty, and placed an 8 millimeter fluency on the left. The reason that we did this was to make sure that the left side still had appropriate flow after the patient's fluency had been placed on the right side. Follow-up studies revealed excellent flow. Angioplasty was performed to seal the stents appropriately. For more information, please do not hesitate to contact me. Thank you for your attention. tpmmd@hotmail.com.